Good evening, everybody, and welcome to our first webinar of the Stop the Pressure Week. My name is Dr. Jeannie Donnelly, and I am pleased to chair this event on behalf of the very hard-working UK Four Nations Stop the Pressure campaign group. This is a truly collaborative group which is supported by the National Wound Care Strategy Programme and the Society of Tissue Viability. We are also supported by some of our industry partners. By background, I am a tissue viability nurse based in Northern Ireland, a lecturer with the School of Nursing in the Queen's University Belfast, and Vice Chair of the Society of Tissue Viability. Our goal this evening is to consider key factors which place babies and children at risk of pressure ulcers. And in keeping with our campaign theme, Every Contact Counts, we plan to explore how we, as clinicians, carers and parents, can ensure that every contact counts to maintain the quality of life and prevent pressure ulcers occurring in this very vulnerable population. But before I go any further, I would like to ask the panel to introduce themselves, and I will start with the Society of Tissue Viability Chair, Sarah Gardner, who is going to kindly help to moderate your queries and questions. Sarah.
Thanks, Jeannie. Hi, a huge welcome to everybody to this really important webinar tonight. I'm Sarah Gardner, and as Jeannie said, I'm Chair of the Society of Tissue Viability. My background is tissue viability, community nursing first of all, and then tissue viability. So yes, I'll be moderating today, and I would really welcome your questions and comments. You've got two ways of doing that. You can put comments or questions into the chat, or you can post them into the Q&A box as well. And what I'll do is, as our amazing speakers or the panelists sort of have their discussion, I will sort of filter those questions and put them to the panel. So huge thank you again for taking time this evening, and it's going to be a great webinar. Thanks, Jeannie.
Thank you, Sarah. I'd now like to ask Sharon Doyle to introduce herself. Sharon, we're really delighted you're with us this evening. So if you'd just like to tell everybody a little bit about yourself.
My name is Sharon Doyle. I currently work for Shine, the spina bifida charity in the UK. I'm a support and development worker for the South Eastern Trust. And I'm also a parent of two children that are 8 and 12 who both have spina bifida. So I'm here as a parent rather than a Shine representative tonight, but I'm very happy to be here.
And Sharon, as I said, we're absolutely delighted that you're with us, because I think that as a parent of two children at risk of harm from pressure ulcers, your lived experience brings great knowledge and value to this discussion. So thank you.
Thank you.
I'd now like to invite Brenda McCann to introduce herself.
Hi, my name is Brenda McCann. I'm a sister in the tertiary neonatal unit in Belfast, Northern Ireland. I am also the chair of the neonatal surgical group in Belfast as well, and I'm the nurse lead on the neonatal network for Northern Ireland as well. And my background is paediatrics, but I've specialised in neonatal care now for 15 years.
Thank you, Brenda. Claire Gardner.
Hi everybody, my name is Claire Gardner and I am the paediatric tissue viability nurse within the Children's Hospital in Glasgow. Kindly been asked to come along here tonight to speak about pressure ulcer care in paediatrics, and looking forward to the discussion that's going to evolve from that.
Thank you very much. Sarah Sharp, would you like to introduce yourself?
Hi, I'm Sarah. I'm a community children's nurse in Bedford. I'm also manage the Children's Tissue Viability Network on Facebook, which helps raise awareness for pressure care for children. So I'm really pleased that the Society is running this event tonight, and I'm really interested to see where this goes.
Thank you very much, Sarah. And last but certainly not least, Sue.
Hi, my name's Sue Flavin. I'm a clinical nurse working with a pressure ulcer prevention intervention service. Quite a unique service. We work with rehab engineers, so they're speech specialist seating specialists. My background is plastic surgery for the last 30 years. And I have a particular interest in pressure ulcer prevention management in spina bifida and children with disabilities through our vulnerable spines pathway.
Thank you very much. So guys, as you can see, we have got a very knowledgeable panel, and I'm sure they'll be very well able to answer any questions that you might have. So I'm going to start off with a question for Brenda. Brenda, when I come into the regional neonatal unit, I'm always struck by the fragility of the very early low birth weight babies. In fact, I remember when I sort of first became a tissue viability nurse, and as a generalist coming into the unit, I was probably quite scared of the babies. I was wondering if you could outline some of the challenges that your team are met with in terms of the general health of these tiny infants and the impact that this has on their skin care.
Yes, Jeannie. So to be in the tertiary unit for Belfast, we get all extreme preterm delivery, so less than 27 weeks are all delivered on our unit. And those extremely low birth weight, so all below 800 grams. Our smallest baby to date is 369 grams. So with that brings a lot of issues for not only the neonatal care, but looking after the baby's skin as well. So complications associated with prematurity can be due to underdeveloped and compromised skin. The quality of the skin depends on the gestational age, and as I said, we are getting those extreme preterm babies that are being delivered. And in that extreme preterm cohort, the skin is very fragile and very translucent. Compared to a baby that's born at term, the epidermis of a preterm baby has fewer cell layers, so that makes it very vulnerable then to injury and heat loss. It also increases permeability to exogenous materials, fluids and electrolytes as well. The dermis in the preterm baby has less structured protein connected to the epidermis, and so this leaves the preterm infant then susceptible to skin injuries. So those caused by medical adhesives, medical devices that we're sort of using, all the equipment that we need to support that baby's life and get it to grow and get it to develop. So preterm babies that are admitted into the unit, then we discuss with their parents. We have implemented family integrated care into our unit, so the parents are very much a part of the care giving in the unit. And from an early start into the unit, we have developed a pathway for the parents, and we've also developed a pressure damage information leaflet for parents on preventing and what to do should they then see that their baby has developed a pressure sore, and who to seek out then for help and guidance.
Thank you, Brenda. I know that when I come into the unit, I mean, some of the babies are you know, they are so fragile, as I said, and they have great issues, obviously, in maintaining sort of oxygen saturations, etc. Do you find that repositioning the babies can impact on that? And how do you manage those sort of really difficult situations where you need to reposition the baby, but it's, you know, their wee sats are dropping?
So again, it can be very complicated, so it can be very distressing for the parents as well, seeing that if we're trying to position their babies, that they do drop their oxygen levels, they drop their heart rate, and then that can be an impact for parents on the bonding process as well, because the parents don't feel that they want to put their hands on their baby because they've seen when the nurse does it, then this is what happens. So it is a challenge. Equipment is changing quite rapidly, especially for these extreme preterm babies. We have an excellent allied health professional team who work alongside us, from dietitian to our OT and our physiotherapist. So as part of our family integrated care plan, we have developed a teaching package both for parents and for nursing staff as well. And it's all around that positioning. How do we position? We're looking into a lot of other issues such as metabolic bone disease with these extreme preterm babies. So we're looking at two-person cares, making sure that we're not putting that little baby under any excess pressure. And especially when we are doing those turns, we try to aim to do 4 to 6 hourly. It's a balance between not handling the baby too much, but again, not leaving the baby in one position for any length of time, so that we're not causing those issues with either equipment lying underneath the baby or shearing off the skin or moving the baby up and down along the bed sheets. Again, it's getting parents involved in that as well. And if they feel that they can have a positive impact by touching their baby, it encourages them and helps them as well.
Thank you. And how much of an issue are devices in relation to pressure damage, Brenda?
Devices would be quite a big part of our injuries that we see in our babies, ranging from face masks on the face with CPAP or with our NIV support, or from our intubations as well. We tend to find a lot of our damage is done around the nose area, so along the bridge of the nose, to the septum and to the upper lip as well. And again, a lot of it is educating. It's educating the staff, it's educating the parents, it's educating with the new equipment that we have as well, to ensure that everybody understands how we actually attach this to the baby and what it is that we're looking for. If we do have pressure damage, we've just rewritten our new pressure awareness guidelines for all staff. And from that, we've taken on a lot of education and teaching with both medical staff, with our nursing staff, and as I said, with our parents as well. And it's ensuring that everybody, when they do see something that they're concerned about, that they tell the right person and that we get the treatment as soon as possible for that baby.
Lovely. And have you found prophylactic dressings helpful, Brenda?
We have done, so originally in the unit we would have used quite a lot of extra thin Juvederm, which we have now moved away from, because we felt that was impacting again on the babies as well. Some pressure damage was there, we were using the dressings, and people weren't checking on it, that was being left on for quite a long time. It's quite adhesive as well. We were lifting it off, we were lifting some of the tissue with the baby. So with our education team and with Jeannie and myself, we have created a new pathway. We're more into the Mepalex Light, and we've been using quite a lot of Silflix as well. And we do find that these are making quite a good impact on the pressure damages that we would have previously seen on the babies, especially around the nose.
Jeannie, can I
Yeah,
come in? There's been a question from Catherine around this very topic about babies requiring CPAP. To give pressure relief, they switch between masks and prongs, but also by removing sort of hourly, just slightly removing it to observe around the nose. And the question is, should we gently rub to help the blood flow around the nose or not?
In our unit, we would advocate for its gentle stimulation around that. Again, we don't want to rub too hard in case we rub and put any more pressure on that baby. But again, yes, that frequent sort of lifting off of the mask just to ensure that there is nothing around the area. We also would do, again, between 4 to 6 hourly, we would change our face mask to our prongs as well. We have 2 different types of CPAP machines in our unit. And they have 2 different interfaces, and we have when we initially brought the newer interface in, we were getting quite a lot of pressure damage, but again, it was education with the staff. Previous where we would have had our CPAP interface, and then we would have had tapes to the side where we would have pulled to get pressure. Our new system now, we don't. Our tapes are literally just for stabilization. So we had a big issue between nursing staff who were used to pulling the tapes to get a good seal, as opposed to now we don't need to pull those tapes, we get a seal because of the interface that we're using. So again, it's that sort of educating the staff, you know, between one system to another. But frequently we would expose that nasal area and let the blood flow around.
Thank you so much. Any other questions for Brenda at the minute, Sarah?
There was a question around about specialist mattresses within the crib, I suppose, you know, where the neonate is lying. Is there anything specifically that you end up sort of using?
We are the one we would typically use in our neonatal unit is the repose mattress, and that would be used quite a lot with our spina bifida babies or any of our extremely large sedated babies who aren't able to move around, who are maybe quite oedematous, to ensure that they're not getting that pressure damage from lying in the one position and lying on the mattress of the actual incubator.
Thank you.
That's all the questions for now. Thanks, Jeannie.
Lovely. Thank you. Thank you, Brenda. Sharon,
Thank you.
we had a short chat in preparation for this webinar, and I was very taken by quite a lot of things that you said. The first related to just how different your children are in relation to their pressure ulcer risk factors. And I wondered if you would like to chat about that and just tell us about your children and your experience of pressure ulcers to date.
Well, spina bifida has been described for a long time as a snowflake condition. There are no two babies the same, and my family is living proof of that, really. I have a son who is 13 and he's very tall and very slim, and he's my child that we need to try and look at his bony prominences because they're very obvious. And he has been like that from he was a very tiny baby. My daughter, on the other hand, is completely different. She is curvy in all the right places, and she sort of has had sort of a lymphedema diagnosis recently, so her legs are quite heavy and swollen, and she has very few bony prominences, but the issue we have with her is that everything is tight. Her socks are tight, her trousers are tight, her splints are tight, so everything with her is tight, whereas everything with my son is very loose, and his splints are, there's quite a lot of movement in them, and you have to sort of pull them quite tight to try and keep them from moving to stop the rubbing. But then when you're pulling them tight, then that creates another problem, you know, where the straps are touching the skin. You have to be aware of that and things like that. So I have two very different children, and they have had very different experiences. My daughter, she was born with Talby, so she had a long series of boots, bars, plasters, you name it, she's done it. So we did struggle a lot with her whenever she was in her, plasters were fine, boots and bars are a whole other series of drama. So she was getting quite a lot of sort of tissue damage at the top of her foot, you know, where the straps would be quite tight on her wee foot. So it was constantly a battle to try and see, can we position our foot correctly to try and correct the talibes without breaking the skin down. And whenever she's in the boots and bars for 23 hours of the day, there isn't a whole lot of rest for that wee very small foot. And it's a lot of pressure on a very small foot, and she can't tell you that it's sore because she has no sensation in her feet or very limited sensation. So yeah, it's tricky. And then as she's got bigger, you know, she's navigated out of the boots and bars and into her splints, her orthosis, and those she wears all day every day. And they're one of those things that's a challenge for so many parents with wee ones that have spina bifida. They don't have the sensation that you and I have. So they can't tell you that there's a pinch in their sock, or there's a wrinkle, or something's too tight, or something's annoying them. So especially whenever we get new orthotics, it's very important for us to keep an eye on sort of wearing them in, as such, I suppose is the word. And we've had an experience where we've been wearing them in, and on one check she's fine, and the next sort of half an hour you take the shoe off, you take the splint off, and she's got a big red heel that did become a blister. So thankfully the blister never really broke down, but there was that damage, and we had to stop wearing her orthotics for nearly a month to try and get her skin back to the strength that it had, you know, without creating more damage, which then is another problem because she's not wearing her orthotics, so her foot is wanting to drift. So it's very much a juggle, what is best for the child, what's best for the skin. And as a mummy, it's very hard to know, because you're not really given an awful lot of information.
Yeah.
So
And
it's
I don't want to
learning on the
interrupt
go.
you, Sharon, at all, but I was just going to draw out that point, because at our prep meeting, Sarah Sharp, who was there, had asked you that question about what education did you receive on pressure ulcers, and did you receive any written information? So I thought it was quite important to hear what you had to say on that.
Really, as a parent, you get very, very little information. You get a tiny wee piece of paper with your new splints that sort of explains, you know, you need to wear them in. Don't just suddenly put your child in them for 6, 7, 8 hours in the day and not check them. You know, so they do tell us when we get new splints and things like that, that you need to build up the child's tolerance, and you need to check, you know, take the splint off and check. But other than a piece of paper, you know, the paper comes with the splints. Nobody goes over the piece of paper that says, this is what you need to look for. If it's red, do this. If it's whatever, do that. You know, it's sort of, if you're not smart enough to look at the piece of paper, you could potentially miss the fact that the information is there. There's very little, I suppose, given to parents, and it's one of those things that you sort of learn as you go along, and learning as you go along sometimes isn't the best way to do it, because by the time you've learned the lesson, the damage is done. But it's probably something that we should be looking at as a health service, I suppose, but it's where to start, and you guys are the place to start, I suppose. So but yeah, lots of parents don't know what to do, and you know, they're looking for information and they're not necessarily going to the right person. It's you've got a physio appointment, so you'll go, this is red, should it be red? And the physio then is going, oh well, it shouldn't be. But you know, so by the time you get to see the person that you need to see, it could be weeks before you've contacted the right person. So yeah, there is, I would say as a parent, there is a big gap.
Thank you. Yeah, and that's something that hopefully we can work together to address. You know, so thank you for that. So in March 2021, the Shine charity produced a report entitled the 1,000 Voices Report. And that report to me was so interesting because it looked at the impact of aging on the lives of people with spina bifida. And I remember being really shocked by the fact that a third of their members had suffered a pressure ulcer before the age of 20. We often think of pressure ulcers as something, you know, that happens to older people, but a third of their members had suffered a pressure ulcer before they were 20 years old. I know that you have a particular interest in the care of young people at risk of pressure damage due to a spinal deformity. So I wondered if you could outline for the audience the trigger points in relation to pressure ulcer harm.
Yeah, and I think my interest in spina bifida as children came initially from nursing adults and listening to the stories, not only from the patient, but also the parents. And they very much reflect what Sharon has said. Very little information was given to the parent when they were children as well, and it tend to be information in hindsight, so which is not good for prevention, is it? Which we're all about today. And I think a couple of things which are apparent is in 2014 there's a lot of data on spina bifida and spina bifida incidents as well, which is fantastic. So we've got a wealth of data out there in the UK, but we don't tend to translate it into maybe pressure ulcer prevention. And the increase of children living till the age, an elderly age, is actually 90% now. So we are looking at an aging population. And the way I look at spina bifida is that we're almost looking at the new generation of pressure ulcers as well. So as the children are becoming more independent and living longer, we have got that increase in pressure ulcers as an adult. So hence going back, looking at the children as you know, spina bifida adults as they were children. So key points, yes, key points that we find, and again, there's very little data out there, but when you look at the neurological defects, and the one paper which I've got in that slide, Jeannie, which I've interpreted, I don't know whether you can put that up now or later.
Yeah.
I can pop it up now if you want,
you.
Susan, yeah?
Yes, please.
No problem.
And Sharon may find this interesting with her children. And
can you see that?
Yes.
Yeah, so we have a spinal injury path, vulnerable spine pathway, because all our children with spina bifida at the moment are closed by one particular pediatric surgeon who does all the closures along with the neurosurgeon shortly after birth. So we tend to pick the patients up through him, and we've seen a lot of children with spinal wounds, but the data from the graphs at the lower end, I was really interested in, even though this is 2015 and I think it is American study. As you can see, you know, we're looking at age 2 to 10, and whereas the most prevalence, which generally in spina bifida tends to be about 12% of children, and also I got a little quote here that 27% of children with spina bifida at some point will have a pressure ulcer between birth and adolescence. So that's quite a high number, which I don't think we capture. But I think in the graph, it showed between the age of 2 and 10, most of the pressure ulcers were developed within the foot area and the lower limb. So, but within the posterior pelvis, you'll get 10. Okay. So when you move to the 10 to 20-year-olds, the prevalence of foot ulcers increases. But if you can just imagine the comparison between the posterior pelvis from age 2 to 10 to 10 to 20, that's a striking difference. You know, that's a huge increase. But what we'll see is children with spina bifida in the sacral region will very often come off their feet, say, or they will become more wheelchair dependent in that transition period between 11 and 15, because the patients, the children were using calipers, but either they had to stop using the calipers because of pressure damage. So that's hence why the increase is there, prevalence-wise, possibly in the feet and lower limb, is possibly due to ill-fitting devices. You've got huge growth spurts as well. So the device is very often out, you know, they grow out of them before a new device can be made. So you've got all that sort of, as a parent, you've got all that to juggle. But very often the child becomes too heavy for mobilizing themselves, or you start getting an increase in the spinal deformity, so therefore becomes more difficult for them to mobilize. So therefore they become wheelchair dependent, and that's where you may be finding the longer sitting times in a wheelchair or on other surfaces, more sedentary, because they can't be as active on the calipers. So that could be representing the increase in the posterior pelvis. And what, because we deal with children from 6 months spina bifida up to the age of 17, and then obviously we see them as adults. When you've got a child in their toddler years, and Sharon may be able to support this, where they can move, they will move. So we get a lot of bum shuffling. So literally a child will go from A to B because they want to go from A to B in any form or way they can. So they'll either roll or they will bum shuffle. So you're getting a lot of problems with regards to friction and things. Also, they start pulling themselves up. They start using sofas, which is great because they're in amongst the family. But from that, then you can get a lot of trauma. Then they go into the nursery or start going into primary school. They're out of the chair, possibly a little bit more. They've got more surfaces to use. Car seats, we find when a child has less mobility, they go into a wheelchair, they're very fixed, so they become less active. In school chairs, they tend to be harnessed in, so they become less active. When they are on the floor, has the school or nursery got the facility to allow them to be active in a safe way? Also, we get into secondary school then, so a lot of spina bifida children will be able to go to mainstream school now, so they not tend to go to special needs schools or supported needs schools. So they're in a mainstream school, and again, are there facilities to manage that child with regards to getting them out and keeping them active? Are they able to participate in PE? You've got the transition to puberty, which Sharon, you're going to have coming with yourself. So you've got that. They're going to be more independent, and they're less dependent on yourself for continence issues or personal care. So you've got the reduced skin checks. They'll start taking more risks. And we see that not only with spina bifida, with any child, they start taking more risks. And obviously you've got that potential reduction then of accepting advice. A lot of the children have long periods in hospital where they are immobilized because of the lower limb orthopedic or upper limb orthopedic surgery, and that is one of the 7 factors picked up on that study, which is a key element to putting these children at risk. So you can see there, I'm not going to read out all of that. This is a point of discussion. 16 to 19-year-olds, we've got extra transition into college. We've got the facilities in college. One chap, he'd had his first pressure ulcer at the age of 17, purely because he was in college and the desks couldn't accommodate his wheelchair, so therefore he got out of his wheelchair and sat in the college chair, and that was the start of his pressure ulcers. We had another gentleman who had gone out on a date, and with a lady, and he was in a pub, and he said he got out of his wheelchair and sat on the pub bench with her, because they were going out for a meal, and he felt awkward being in the wheelchair. So you've got that more socially independent to that. So you've got more risk taking in order to fit in. But alongside that, you've got that deterioration of posture. And I think what happens then is, as the child, spinal deformity can deteriorate significantly. You've got that change of posture, you've got changes of pressure, all affects the pelvis. And then when we see the transition into adulthood, all those services which were keeping that child as safe as possible tend to get withdrawn. And, lots of independent living, especially. But the one thing I will highlight from the paediatric point of view is a lot of the patients I see from being adults, very often it's that previous bad experience. Hopefully now we're in 2020s, we won't see the experiences that children had in the 1980s, 1990s, even into the 2000s, where the management of pressure ulcer was to put them to bed, or they'd end up in hospital, and they were literally, all their independence was taken. So they're frightened of coming forward with any problems. So I think from a paediatric webinar point of view, I think my emphasis would be, we've got to give that child or that young adult a positive experience, get in early, sort it out. It doesn't have to, we don't have to go into those extremes.
Can I just come in, Susan? Sorry, just ask a question. It's about, I think Sharon mentioned about getting information on a bit of paper. You talk about education. Is there a right time that you would give a child information about pressure ulcer prevention?
Yeah, and that's where I would come to the group, because we do the vulnerable spine pathway. It's about, and we see children from the age of, as I said, 6 months up until the age of 15. I find is it best to give the child information earlier? But we don't want to worry the child. Should it be part of a transition period anyway, from a child into adolescence? So bowel and bladder management tends to start looking at the child to be more independent with their personal care. So is that a time to start introducing skin checks? Because that's when skin checks tend to drop out. So children don't want the parents to look at their skin, because they're becoming more sort of independent. So is that the time to give, when they can understand it as well? Yes, we can give information to the children when they're younger, but can they understand that? And I think what we've got to remember as well is that children with spina bifida are more prone to educational levels. So they may display less ability to problem solve or understand or sequence as well. So I think we've got to incorporate how the child understands, and I think therefore it's got to be individual. But when do we approach it? Do we approach it alongside other care? Personally, I think yes, because it's not an additional need. It's a need amongst other needs, and I think they may be more accepting of that information at a particular point in time. But I'm open to the panel who I
think Sarah maybe has some thoughts to add.
From a community perspective, I think it's vital that we involve children from the earliest stage possible, if their level of understanding allows that and their interest allows that. Children need to be heard, and they need to I took a child to conference last year, and he's still at the back of my mind right now, that If they're displaying pain and explaining that something doesn't feel right, we need to listen to them. A bit like what Sharon said about the children's orthotics. If we're pulling them tight, they're going to be the first people to tell us that feels tight. And I think that then allows them to advocate for themselves in different perspectives, different areas. So if they're attending school, the children go among various different places in the day. They'll be on transport, they'll be at school, they'll be at a physio appointment, hospital appointment. If they're admitted into hospital, that's sometimes not to blame, because we know children get more pressure ulcers when they're unwell. But they can advocate for themselves sometimes. They actually, I haven't been repositioned in a while. You know, could you move my leg? Could you move this? It's a bit sore. And I think we need to ensure that, especially in the community, we give them written advice so that can go between these different places with them.
Thank you. Any further questions, Sarah, before we move on to the next?
There's some comments and some questions. I'm just wondering whether there's a question about advice for an adult TVN trying to start this journey into pressure ulcer prevention in neonates and children's services. I think as a panel, we had this discussion earlier around a small number of specialist sort of tissue viability children's nurses there are in the UK. I think we'll probably come to Claire about this later. And that we have adult nurses, nursing nurses who are trying to advise clinicians or parents of children. So it's really just any supporting advice. Maybe that will come out as we progress through the discussion.
Okay, thank you, Sarah. Can I move to Claire Gardner? Claire, in relation to skin bundle care, I mean, we're all used to sort of being taught about, you know, surfaces and skin checks and keep moving, etc. But I'm wondering what, if anything, should we do differently to protect children from pressure ulcer harm? For example, do you find risk assessment tools useful in children in helping to plan the care?
So we were speaking about this earlier on before we started, and how there is a variation within the UK of different risk assessment tools available. So that there is our starting point to reassess that. We have recently started up a paediatric group, which also Sarah is part of. And that would be one of the first things that we'd be looking into to see, because as we know, quite a lot of the documents and policies and guidelines around pressure care are derived from adults and adult studies. It's very difficult because of the numbers of paediatrics in relation to adults in the population. So getting the case studies or clinical trials to see what works and doesn't, it's mostly what we have found from practice. There's very little studies, and a lot of people ethically don't want to. You can't ask a child if they're too young, and sometimes the parents are scared to let you try something new in case you do harm the child. So I think it's about looking at the risk assessments that are out there. Are they fit for the paediatric population as well as neonates? And if not, what adjustments do we need to make to ensure that we are capturing all the risk factors that could cause damage to these children? We know that majority of pressure damage in their younger ones is through device related or mattress from the occiput because of the body height and weight ratio. The head's obviously much heavier. So it's about, I think, educating staff. Quite a lot of the time, if you were to say to staff, like, name an organ of the body, they're very quick to tell you about the liver, the heart, the lungs, but they very rarely say the skin. And obviously with it being the biggest organ of our body, it's about protecting it. And I think maybe staff become so focused on what the child's admitted with. And if they're coming in and say they're having seizure activity and that's ongoing, they focus more on that and not, oh, that's patients maybe shearing their leg up and down as they're having involuntary movements. Is that going to have an impact on their skin? And like you were saying earlier, it's more when that redness or that blister starts to happen that the damage is already there and we're not picking up on it quicker. So hopefully by forming this group again, we can look at it as the kind of paediatric TVNs to see what we like from the risk assessments, what we feel works, I think whatever we use, we need to make sure we're capturing everything that's going to trigger a risk factor, but not make it so scary looking, because a lot of the time if nurses are busy and they look at a chart that's got all bits going off from it and tick boxes and all these questions, it puts a lot of people off, and they do tend to copy what somebody's done before, which I'm not saying is right, but because it's seen as another piece of paperwork that they need to get through in their shift, then they're not fully understanding what is this piece of documentation asking me to do here, and therefore what plans do I need to put in place to make it more the preventative part of it, as opposed to waiting for the damage to come, and then how do I now manage this and not get it any worse. So I think it's about really bringing home about the skin, about how easily it can break down, about the children not having maybe as much subcutaneous fat, or yes, we have the same layers of skin as adults, but it is much thinner, and really homing that in so that they do understand the importance of checking skin, catching the red areas quick, and also making sure that the contact that they are in touch with either does the pressure redistribution or relieving part of it, and if not, the devices part, like are we putting that protective layer in, are we taking it off and checking, can we move from having prongs to a mask and fluctuate back and forward so we're not got that one contact there the whole time. And obviously remembering that different parts of your body have different thicknesses of skin, so your bridge of your nose will break down much more quicker than having a device on your arm, a blood pressure cuff, you know. So it's getting people to also think about that, and absolutely getting parents involved, because a lot of the time they're sitting at the side feeling less powerful. They're used to doing the care for their child at home. They come into a hospital setting. Some of them are very good and still do that, but they want to have a bit of control over something that they're not having control over. So if you say, when you've got them stripped down, when you're doing that wee change, if you're getting their jammies off in the morning, give me a shout, let me come in and cluster in the care, so you're not in and out and saying, right, well, that's 11:15, I need to check your skin, even though they were just had all their like pajamas and stuff changed at 9. You know, it's about trying to link in with parents and doing that kind of partnership, working while you're either in the ward or at home. You know, try to time things so that you're doing things that are less obstructive to the patient who just wants a bit of time because somebody else has come in and done their medicine, done something else to them, and you're thinking now somebody else is coming in and want to strip me and look at my skin. So yeah, I think it's about clustering the care and getting parents involved. And absolutely, if the child has the cognitive ability and considering their stage of development and understanding, then absolutely getting them involved as well. You know, they can easily check. Like I was saying to the panel before we started, we had a boy who used his mobile phone as his camera to take pictures. He was a traumatic spinal injury from a skiing accident. And he got by-in because his skin was starting to break down, unfortunately. It was a bit too late, but he then recognised the importance of how quickly the skin could break down, and that became part of, like, you brush your teeth in the morning, that was part of his regime, was to then check his skin and do it at regular intervals so that he's catching it quick.
Thank you, Claire. Sarah, I know did you hand your hand up? It's down again. Did you want to make a comment?
As always. I agree with Claire that actually hearing what she was saying about the risk assessments is so important. We've seen a massive increase in our pressure care due to just changing the risk assessment tool to something that's engaging and simple. I think the what does this mean factor is so important with pressure care. Sometimes we focus so much on what a score this means, and we actually need to focus more on the care plans that are then put in place and the advice that we give to parents. Sharon said earlier about the fact she hadn't been given written advice, and that's something in our trust we're really trying to change, and I think we need to change nationally, is that we do now give out written advice that follows the skin bundle to all families with complex needs, to ensure that they've got that advice and they know who to go to, because I think that's been shown as a real gap in care. And I also can see somebody has asked about school teams in the comments, and I wanted to say that one of the biggest helps we've had is engaging children in their care and skin inspections. So when they go swimming, you know, having a little look then, as Claire said, fitting it in around what they're already doing, so it doesn't become this additional thing of, oh, you're taking me off to a room to look at my skin. Fitting it in and getting them to report back to us in whatever method or way they can. You know, is an area painful, is an area sore? Photographs is a great idea for somebody to be able to self-check. So yeah, just really agreeing with what she said, because I really do think that's so important.
Thank you, Sarah. Sarah, have you any experience of pressure ulcer passports? Do you think that these might help children at risk as they transition through various care and educational settings?
So this is something that's come up at quite a few recent conversations with TVNs, and when we've had sort of look at root cause of where pressure areas have built up, is the children transitioning between the different areas of care. So yeah, I have recently been looking into pressure passports for us to use locally with our local hospital, and they've been really helpful at helping me put together sort of history that can go with most children with complex needs will have a hospital passport they go in and out with. So to put this alongside that, so we can see what pressure ulcers this child had before, because we know if they've had one, they're going to be more at risk of another. And then looking at what medical devices they have in the community and what works for them at home. So you can put really individualized things on there, like you know, I like a V-shaped pillow between my legs because that helps with the pain I get and the redness on my knees. And if these things follow the children into hospital, then we can continue that care and give them that continuity that they need for their skin. And also for the hospital setting, to be able to put on, if the nurses that see the child on the ward can input that care as soon as they arrive, because we do understand that to get a tissue viability assessment in hospital doesn't always happen on the day they arrive. And if we can prevent this pressure build-up, then we can prevent these ulcers that do occur when the children go in.
Thank you. I can see Sue has her hand up. Would you like to comment, Sue?
Yeah, just quickly, one thing we found with really high risk patients coming in and out of hospital for various reasons, we gave them a little card to say, I'm at risk of pressure ulcers, please ask me what precautions or I need. And I think for a child to maybe hold that, or a parent, they can produce that straight away into A&E. So you're almost preempting any risk assessments, and so they can say, I'm known to be vulnerable. Please ask me about what precautions I need. I know your turn then took that on following that. But yeah, I think just, and you could make it really child friendly, couldn't you? Just a little card. So again, they've got ownership, so they can give the card to any healthcare professional, just to say, oh, I've been diagnosed, I'm at risk, and this is what I need to help protect me.
Thank you. Claire, your hand was up. It's come down again.
No, I was just kind of thinking, we've also had patients that go to surgery and they'll pass the endotracheal tube, but they'll pass it down the same nose where they've previously had damage. So we were also looking at that to go, if you know the damage has been there before, and you can swap it to the other ear, or you can't, but then put a protective barrier, and people don't always think about that either. So sometimes you might get patients that have had damage, their skin's still fragile, as we know it takes about 2 years for skin to mature. Then you're thinking, it's not just, we're concentrating on just now about like ward settings and communities, but as we say, pressure damage can happen anywhere. So it is thinking about all these places where they are going to be more susceptible, especially in theatres as well, where they're maybe on, they've been fasting for a long time, so the nutrition's a bit poorer. They're maybe getting anticoagulant medication where their blood's a bit thinner, so it's taken into consideration all departments really. And I think really linking in with your multidisciplinary team, we've also had some neonates, I don't know about you, Brenda, that have survived at like 22, 23 weeks. And even the masks for the 24-weekers are still too big. So we've kind of fed that back to industry to say if we are surviving these children, then we actually need the equipment to go along with that. So yeah, we could talk about this all night, couldn't we, really?
Well, absolutely could. I'm just thinking we've 5 minutes left. So Sarah, I'm just thinking if you want to make a comment, and then I'll hand over to Sarah Gardner for any final sort of questions and queries that we can maybe answer as a panel.
So I was just thinking of, you know, with the pressure passport, it being quite personalised to that child. And you mentioned about repositioning a moment ago, and I think we often get asked about how often children should be repositioned. And I think the answer is very individual to that child. So if we know what works for that child normally, then we can adapt that into the hospital. So, for example, this one I've got in front of me, my mum turns me twice during the night. If we know that's what he needs when he's well and in the community, then we know that he's going to need more than that when he's unwell in hospital. And trying to match the equipment. If we can know what that child sleeps on at home, whether it be foam or an alternating mattress, then we can know when they go in hospital what sort of equipment needs to be ordered on admission. So yeah, that's all I wanted to add. Thank you.
Thank you very much. Sarah, just before I hand over, Sharon, do you think something like a passport or a little card would be helpful for your children?
Sorry, I couldn't get the mute button. Yeah, I think it is something that would be very helpful because, as we've said the whole way through, children are very different. No two are the same. From their physical needs, their emotional needs, their psychological needs, and just what they can cope with. So it's very important, you know, that each child is an individual. It's not just, oh, you're in the 10 to 12 bracket, we'll do this with you. You know, they are so different. And I think, you know, continuity of care is so important. And, you know, as a mummy, you try your best to do all the things that you do to try and keep your child safe. And sometimes as a mummy, it's very hard to hand that over to a nurse that you don't know. You maybe haven't met them. Sometimes you do build a relationship with a nurse, but that's only through long progressive stays in hospital. So most times when you go to hospital, you don't know any of the staff. So for you then to turn around and try and leave, it's very, very difficult. So if you have a passport, you can fill in all that information that is important to you, that you know that if, like, for example, my kids sleep with their feet up and they, you know, it's just wee silly things. It's not that, it's not that it's a very technical thing. It's just for their own comfort. You know, they like to do this, or, you know, to try and reduce swelling in their feet, they sleep with their feet up. Or my son, he has scoliosis, so he tends to sleep more comfortably on one side than the other. So it's, you know, not necessarily even a medical thing. It's so important to try and keep the child happy. And, you know, if they're happy and they feel safe, they're more inclined to sort of, I find they're more inclined to recover better from all sorts of things. You know, kids are so resilient, and they bounce back from all sorts of things that would knock an adult for six for a long time. And, you know, individuality
I'm not sure
is the key,
Sharon.
and a passport is something that a passport is one of those things that you can individualize for each patient. So it's not just sticking them in a box and saying this is what happens to you. So I think they would be very beneficial.
Absolutely, thank you. Sarah, sorry, I know we're really coming to the end of our time now.
Yes, I mean, it was just someone asking about the passports, whether it's something they would create themselves, or whether there is one already available they could take a look at. I agree, you know, what Sharon was saying. I think probably what they are is that, you know, they might be a standardized template, but you would create a very personalized sort of plan within that. So they're asking whether anything is available or whether they would put something together themselves. Is there anything that can be shared?
Sarah Sharp, do you have anything that can be shared?
So I can probably send something through later this week.
Lovely.
And shared. But it is very, I think it's important that it's built with the hospitals that the child's going to be admitted to, and is something that's realistic for both teams to be able to achieve.
Okay, thank you. Claire, I know you have your hand up. Just a very quick comment, because we really are at the end of our session now.
Yeah, no, it's just, yeah, it's very, very quick. I know there's a couple of adult TVNs that are on, so it was just to promote Sarah's Facebook group to say, you know, to come on to that, and hopefully myself and a couple of other paediatric tissue public nurses are on it, as well as obviously Sarah from community. So if they're wanting further questions answered, then if they join the group, we can try and help them on that platform there.
Okay, thank you so very much. Folks, believe it or not, that hour has flown past. We've come to the end of the session, and I would really like to thank, on behalf of the UK 4 Nations Stop the Pressure Group and the Society of Tissue Viability, to just say a very, very sincere thank you to our panel, and to Sarah for managing the questions, and to Dawn and Kerry in the background, who've been working incredibly hard to bring this webinar together. Folks, please do check out the Society of Tissue Viability website for all of the Stop the Pressure events taking place this week. And remember, in order to stop pressure ulcers, every contact counts. We've lots of resources for you, ranging from webinars, study days, to videos and quizzes. So thank you so much for all your engagement, and let's just get the message out there that every contact counts. Thank you.